Okay. Bonjour, chers amis, dear friends. Here is Rotterdam, the Netherlands, speaking to you. Dear Jean-François, dear Pablo, and all the colleagues and residents, I hope, also residents, many residents, I hope, because this is a very important Congress, as yearly, as usual. And we are very honored to be invited and to do the presidency of this very inspiring session. And we are thanking also Club RNI for the inspiration and the cooperation, scientific cooperation, also for the enlightenment in the field of abdominal wall surgery, which is really becoming a specialty of its own. It's very important, and it's crazy that in these bizarre times we are doing our utmost as abdominal wall surgeons to find evidence-based truth, and we have to live under drastic measures, many of them not evidence-based. It's incoherent and it's difficult to support, but that's life. And so we are very sorry to have to stay here in Rotterdam without the usual warm personal contacts with you all. And also my wife, she's very depressive because she is counting to dance with Jean-François every year. And even when I wear my Club RNI tie and my button, as you can see, the Club RNI button, she still says it's not a compensation for the warmth she feels of Jean-François and all of you in Paris. So to save our marriage, I hope to be with you in Paris next year again. To conclude, from my part, we have today a very interesting international session on complex abdominal wall surgery, and also an eminent panel of moderators, as you will find out in the next hour. And I'm very pleased to give the words to the first speaker on a very interesting topic. Thank you very much.
Hello, so I'm Catherine Arvieux from France, and I have the honor to present the first orator, which is Professor José Bueno Lledo from Universidad de Valencia. He's head of the Unidad de Pared Abdominal, so abdominal wall unit. So he has a very strong knowledge of the very difficult problem of the loss of domain. This represents a very severe disability for patients who had it, and so we're gonna hear his presentation. He's sorry not to be able to be present today, and but we will maybe try to answer the question as moderators. So let's see the first presentation of Dr. José Bueno Lledo. Thank you.
Good morning, good afternoon. Firstly, I'd like to thank to the organization for his invitation to this meeting, especially to Dr. Guillaume. It's really a pleasure to be here. I want to show you our experience in La Fe Hospital about the treatment of loss of domain in large hernias and the use of preoperative techniques like Botox and pneumoperitoneum. It's a long experience of 2 years. These are my disclosures. Loss of domain hernia involves physiological alterations and changes in the quality of life, respiratory problems, changes in defecation and urination, and negative economic repercussion. A Mexican plastic surgeon, Tomás Ibarra Hurtado, reported in 2009 the Botox application on abdominal wall is feasible and possible. He achieved a significant decrease of the transverse hernia defect, as well as increase of the length after open abdomen management, applying the toxin in lateral muscles of the abdominal wall. Many working groups like mine have adapted these results in this experience in abdominal wall repair. As you know, Botox causes a chemical denervation and transient flaccid paralysis, and the top of the effect of this toxin is in 3 or 4 weeks, and then decreases over the following 5 months. Therefore, Botox increases the abdominal cavity prior to hernia repair and optimizing preoperative period. But an interesting question would be, is botulinum toxin enough to prepare loss of domain hernias? The answer is no in our experience, because the benefit of the Botox alone is not enough in some cases. We need to combine another technique like pneumoperitoneum. So the goal of pneumoperitoneum is to create a controlled progressive distension of the abdominal wall, and the abdominal cavity needs to get used to the hernia content. To make a plan and evaluate the needs of its application, it's mandatory to have a CT scan where we can obtain several parameters like volumes and diameters related to the hernia and abdominal cavity. Hernia diameters are useful to know the possibility of Botox application, and volumes useful to know the possibility to apply mainly pneumoperitoneum. In our experience, Botox is applied under outpatient basis, and we use 500 units of Dysport infiltrated in 10 points, and using electromyographic and ultrasound guidance according to Ibarra's protocol. The 3 lateral muscles are located, in this video you can see, by ultrasound, and we check the viability of the injection with electromyographic guidance. 5 points are identified on each side of the abdominal wall, 2 points in the mid-axillary line between the rib margin, in the upper iliac crest, and 3 points between the anterior axillary and mid-clavicular line. And we managed to identify the best point according to the maximum contractility wave, improving its effectiveness, especially in patients with muscular denervation, atrophia, or fibrosis. But it's interesting to know the volume and the duration of the pneumoperitoneum. In my hospital, the total volume is in function of the hernia volume and the individual patient's tolerance, but the formula is 3 times the hernia volume value in cubic centimeters, approximately a liter a day. And the duration is variable depending on the global volume of air, but approximately it's around 10 days. This video is interesting comparison between pre and post treatment, combining both preoperative methods. You can see sagittal and coronal images of CT scan, so as increase of the length and decrease of thickness of the 3 lateral muscles. And you can see also the abdominal cavity reabsorbs the hernia content. A new space is created due to the effect of the progressive air. Our experience in figures, 105 cases with combination of both methods. Important to remark the most frequent technique was components separation, anterior and posterior, and ribs stopa technique. After a follow-up of 38 months, we found an 8% of recurrent I think is an acceptable figure treating these complex patients. But apart of loss of domain hernia, another indication of Botox would be the possibility to change a technique like component separation for another less morbid repair using the neurotoxin. We can take advantage of Botox, try to achieve a down staging of the repair. For this reason, we did a prospective comparative study of 80 patients with midline incisional hernia, double 3, according to the European Hernia Society, and the inclusion criteria was transverse hernia diameter between 11 and 17 centimeters. Therefore, two groups, open anterior component separation, 40 patients, versus Botox and after ribs stopper repair, other 40 patients. You can see the interests to find out the results in terms of facial primary closure, complications according to Clavi and Dindo classification, and the recurrence. And the results were better in the group of Botox and ribs stopper. Finally, I want to show you the algorithm of my group. It's a dynamic protocol, which it has been modified step by step, depending on our experience for last years. CT scan mandatory to calculate the diameters and the volumes, and then to calculate the Tanaka index, and we can have a Tanaka index less 20% and maximum transverse hernia defect less 11 and 12 centimeters. We don't need to perform any preoperative techniques, but Tanaka index less 20% and maximum transverse hernia defect 11 and 12 centimeters over. We use botulinum toxin in outpatient management to try the down staging of the repair. On the other hand, Tanaka index over 20% or loss of domain hernia, according to many authors, we need botulinum toxin and progressive pneumoperitoneum. 30 days before surgery, we apply Botox, and in 10 days, roughly, we apply pneumoperitoneum. Remember, we use 3 times the hernia volume value in cubic centimeters. And finally, we need to check the differences in volumes and diameters by a CT scan and pulmonary function test the day before definitive repair. Thank you very much. Bye.
Yeah, thank you very much, Dr. Lido. Very, very intriguing and interesting talk. It would be a great advantage indeed to do minor surgery with help of Botox. And our next presentations will be presented by an authority in the field on complex hernia surgery, of course. It's Professor Miguel Garcia Urena from Madrid. And he will speak on tips and tricks in complex hernia surgery. I'm happy to give the floor to him, Professor Miguel Garcia Urena. It's up to you.
Good morning. Thanks, Professor Guillon and the Scientific Committee for giving me the opportunity to be here in this 16th edition of the MESH 2020 in Paris. It's a great honor for me to be in this Congress again. These are my conflicts of interest, all related to, of course, of meshes in abdominal wall. And first of all, I would like to make a short tribute to Dr. Nowicki, who really scored quite a good goal describing the traversal abdominal release that has helped me so many patients of complex abdominal wall. Before going into the technique, I would like to remark the importance of making a very good preparation for the patient. We cannot go ahead with our excellent technique or whatever without any optimization of the patient. This is quite important and is part of the procedure itself. So remember, just regarding with the technique, I would like to give you some advices. One of them is contains 3 messages. Is preserve the sac, take your time with adhesiolysis, and please protect your viscera. You know that we traditionally cut longitudinally the sac, and then we leave half of the sac attached to the posterior layer. So if we have problems with the posterior layer, the peritoneum, because previous operation, we have always half of the sac to use to protect your mesh. And the second part of the sac is attached to the anterior layer. The second advice is to perform an optimal ribs stoppa procedure. This is particularly important here, of course, in France. Because, why not? Because a proper ribs stoppa procedure gives you the clue, the right space to perform the posterior component separation technique. And it consists of incising the posterior rectus as close to the midline as possible, so we can take the most part of the anterior layer, the anterior aponeurosis or linea alba, and we can take also the most part of the posterior rectus to close the posterior layers. My second advice would be to try to keep always the integrity of linea alba when making the ribs procedure. Why this is important? Because cutting the posterior rectus very close, mainly in the cranial part of the dissection, we can injure the midline. So beware of this. So I usually now change a little my way to perform the ribs stop, and I usually stop there in the cranial part. I don't cut more the posterior rectus, and I prefer to perform my peritoneal fat dissection retrocyphoid before starting the posterior component separation technique. The second tricky thing is to find your Cooper ligament, and because I like always to fix my mesh, because we don't have any more extension in the pelvic area there, so particularly in M4 and M5 incisional hernias, I like to put these 2 stitches with long-term absorbable sutures that will fix the permanent mesh of my abdominal wall reconstruction. You'll usually have this accessory obturator vessels over there, but they are not a great deal at all when putting these sutures over there. And this is the great landmarks of to start your posterior component separation technique. The medial incision on the posterior rectus, lateral limit of dissection there on the neurovascular bundles, and the arcuate line in the inferior part. So we can make our incision there, as Nowicki described, starting in the superior part, or we can, as we advocate, to start in a downtown fashion, even preserving the transversal abdominis muscle fibers in the cranial part, going more obliquely. So the tricky thing is to perform the cut on the lateral border of the posterior rectus 1 centimeter or half centimeter medial to the ridge that was initially described. Then we can develop our plane in 2 layers, in a complete peritoneal plane or a complete pre-fascia transversalis plane. In this cadaver picture, you can see here that we can obtain a complete peritoneal plane under the fascia transversalis and the transversal abdominis muscle. As you can see, the peritoneum is very thin and can be easily opened during this dissection. Our landmarks to find the starting of the posterior component separation is to make a very good dissection of the Bogros space and the Retius space behind the myoperitoneal orifice. Identify the neurovascular bundles, the linear quota, and then we can start there our down to up, and we'll start over there our posterior component separation technique. In this clip of video, you can see here that we are just identify the linear quota and then start cutting the linear quota. You can see the thin peritoneum underneath, and then with scissors you can also use your fingers to separate the peritoneum from the transversal abdominis muscle. And as soon as you start cutting parallel to the lateral border of the posterior rectus, you need also to release the tension on the peritoneum, going laterally to avoid injury and tears on the peritoneum that are easily performed when performing the posterior component separation. So release, and laterally, you know that laterally the peritoneal fat distribution of the body allows us to separate more easily the visceral sac from the muscle than near the midline. So it's a tricky thing is to release this tension in the peritoneum. And coming cranially, you can see that we have now make the incision on the contribution of the internal oblique muscle, the posterior contribution of the posterior lamella of the internal oblique muscle, and now we are cutting now the fibers of the transversal abdominis muscle to get in the right plane. Now you can see here that in the inferior part we have been in a peritoneal plane, and now we change here in the cranial part to a pre-transversalis plane. We extend our dissection on the transversal abdominal muscle, and then we are gonna see early the diaphragm, and now the fascia transversalis becomes the fascia diaphragmatica, and I advocate and we advise to keep your plane there in a pre-fascia transversalis plane, because the peritoneum there can be very easily broken. So here you can see that in the cranial part also it's important to make the dissection in a dome shape of the diaphragm. Instead of going completely retroexternal or complete retroxiphoid, you need to go in that way to avoid detaching the physiological insertion of the diaphragm onto the sternum and xiphoid. So you avoid the possibility of a Morgani hernia. And we also advocate to hyperextend our dissection laterally and posteriorly to touch the psoas muscle and quadratus lumborum over there, mainly in big incisional hernias. You can see here the overlap that we can get is more than 15 centimeters almost in all directions. So this will be our dissection, and that in the inferior part of the abdomen we can go pre-peritoneal, and in the superior part we are going to go in a pre-transversalis plane. In the right side on the screen you can see here the view, a drawing from the view in the abdomen, and you can see that we have keep our plane here in pre-peritoneal plane, and the superior part we go in the pre-fascia transversalis or pre-fascia diaphragmatica plane. After performing a TAR, the posterior layer can be easily closed usually, but sometimes we have previous messes, a lot of recurrence, and then we can use our peritoneal flap on a sobable mesh to close the posterior layer. And finally, the abdominal wall reconstruction with meshes. You know that we use a combination of an absorbable mesh together with a very large permanent synthetic mesh that allows us making this configuration and extension in the plane that we have dissected. Not all the permanent meshes are the same, so you need to use the appropriate mid-weight, at least mid-weight macroporous polypropylene mesh to perform this dissection. As you can see here, the distance between the quadratus lumborum on one side to the other could be sometimes even longer than 70 centimeters. So we usually deploy our mesh in a diamond shape and extend over the quadratus lumborum, psoas muscle, Cooper ligaments, and the diaphragm our mesh. Just to remember, this is a recurrence with a fistula tract also we need to make also a small bowel resection, and you can see here that we are using this mesh 50 by 50. This is a strong mesh that we can fix only to the Cooper ligament, both Cooper ligaments, make the stopa configuration at the inguinal area and extend over the absorbable disc mesh. This only a couple of sutures to extend the mesh, and you can see here that without any lateral fixation, the appearance of this mesh before the midline closure. The midline closure must be made with running or fewer of 8 sutures, as Nowicki has taught us, but sometimes this is impossible to completely close, and then we breach some of our repairs and fixed the borders of the breach to the layers of the mesh and use the anterior flap of the sac to close our midline. So here I summarize my advices for a safe TAR, and the message I want to send to you: please optimize your patient for surgery, preserve the sac and make a safe adhesiolysis, protect your bowel, your viscera with a towel, with something that protects or plastic bag to protect your viscera from your dissection. Make an optimal ribs stopa with a lateral appropriate dissection, cranial to the peritoneal fat behind the xiphoid and down to the Cooper ligament. The lateral release of the posterior rectus should be made 1 centimeter to half centimeter medial to the lateral border of the posterior rectus sheath. We advocate to use a down to up TAR and keep your plane in a complete peritoneal plane in the lower third of the abdomen, but in the superior part of the abdomen, please change your plane and go in a pre-transversalis, pre-fascia diaphragmatica plane to meet the diaphragm, and sometimes it's necessary to develop your plane until the central tendon of the diaphragm. Please use appropriate mesh. Forget about use low weight meshes in this abdominal wall reconstruction because they are gonna fail. So please use an appropriate, strong enough mid density polypropylene mesh. And please also try to close all the layers. Of course, the posterior layer should be closed. If you cannot close it, use an absorbable mesh as an adjunct to protect your permanent mesh from the viscera. And try to not to breach, of course, but just in case you breach, please fix the lateral borders of the breach to your permanent mesh. Thank you so much again, Dr. Guillon, for giving me this opportunity, and I'm open for your questions and very good discussions.
Yes, thank you very much. Very useful. Always the tricks of Miguel for our daily practice. And now I like to give the word to one of our moderators to introduce the next speaker, Johan Renard from RIMES, please.
Okay. Thank you, Dr. Guillon and Dr. Renard, for giving me the opportunity to be here moderating also the session. And I would like to introduce the next topic that is quite interesting because the absorbable meshes are coming more and more, and we have better materials. And there's a particular now is presentation from Johan Renard talking about polydroxybutyrate meshes. And it's a quite interesting question that he's gonna answer us. Have they become indispensable for complex cases? I think we are waiting for your answer now. You have the word, Doctor. You can present the video.
Hello, everybody. Thank you again, Jean-François, for your invitation and this opportunity to speak about biosynthetic meshes. How do they become essential for our complex cases? According to the definition of complex abdominal wall hernia, this topic will focus on 2 complex situations. First, the loss of domain, and we know that the treatment of loss of domain may lead to high postoperative complications. And the second situation are the infected abdominal wound that may lead also to high postoperative infectious complications. So this topic will focus on these two situations and will be divided into two parts. First, the loss of domain. We know that this loss of domain will lead to subsequent difficulties after repair, in particular the risk of intra-abdominal hypertension that may lead to respiratory failure and abdominal compartment syndrome. For this reason, we use in Reims the technique of the progressive preoperative pneumoperitoneum, and we published our results in 2016, including 45 consecutive patients. What were our results? First, we published an overall surgical site occurrence rate as high as 41%. We also report an overall surgical site infection rate of 27%. And we then report an overall recurrence rate of 10% after a 20-month follow-up. We argue that our results are not so bad, but the question is, how can we improve our results, in particular decreasing the postoperative complication without increasing the recurrence rate? The second situation is the infectious condition, during the repair. We should use today the modified ventral hernia working group classification into three grades, and we focused on grade 3, in particular the contaminated and the dirty situation. For this situation, biologic meshes are actually recommended. But why? Because from 2010, we were searching the ideal mesh for the repair in case of infection situation. And biologic meshes were thought to respond for all difficulties. They were thought to be the ideal mesh. For this reason, numerous teams used the biologic meshes for the infectious situation, and they reported their results. As you can see, they publish all biologic meshes, including grade 3 or grade 4, but according to the old classification, and even in very last publication, including the German register, they reported high surgical site infection rates reaching for 30 to 60%. Also, using biologic meshes in infection condition, they reported high recurrent rates from 20 to 40%. So, biologic meshes are not so good for the infectious condition. And what do we know today after a decade of using these biologic meshes? This systematic review published by Maria Burmeister probably answer the question, and using biologic meshes, we have no benefit over synthetic meshes, and these biologic meshes showed considerable higher rates of surgical site complication compared to synthetic meshes, and high rates of hernia recurrence. So we used in our unit very much biologic meshes, and we reported good results in 2018 by comparing a Vicryl group versus a biologic group in dirty conditions. And we reported using these biologic meshes of Stratis a surgical site occurrence rate of 46%, a postoperative surgical site infection rate of 33%, and a recurrent rate of 16% compared to the 70% using the Vicryl group. So we are that these results are not so bad, but how is it possible to improve these results? So according the fact that these biologic meshes are, are very high cost and they lead to poor results on infected situation, we changed our strategy from 2016 and we used the P4HB mesh for all infected cases and also for many loss of domain patients. All our patients are registered, are prospectively registered from November 2016. And we use them for the infected mesh in grade 3, like this patient using the PHASIX mesh. We use them for loss of domain, like this patient with PHASIX ST, like this loss of domain patient with extraperitoneal PHASIX mesh, and sometimes for both loss of domain and infective mesh, for example, this patient. So we are very satisfied, but how are our real results? So concerning the infectious conditions, using PHASIX compared to the previous management may lead to fewer postoperative surgical site occurrence, fewer postoperative surgical site infection, and fewer recurrence rates. But these results, unfortunately, are not statistically significant. We showed the same baseline characteristic with same technique and the same follow-up of 18 months. What about the loss of domain? Using PHASIX compared with previous management, the surgical site occurrence rate was the same. The postoperative surgical site infection was decreased using the PHASIX mesh, and the recurrence rate was also lesser. But these good results are also not significant. So as discussion, first, whatever the mesh we use, the technique is essential. And we are to use always the retrorectus plane whenever possible. Second, we use always a large mesh with high overlap, and then always closure the muscles. Because when we don't close the muscle using the mesh in bridging, the postoperative recurrence rate is very high, in particular for the contaminated situation. So we have same or perhaps better results than biologic using PHASIX, but perhaps because these patients are very difficult to treat with high comorbidities, like Pasteur said, but with very lesser cost than biologic one. Only one author published prospective comparative study between a two-step strategy with, at the second step, a synthetic mesh versus one-step strategy using the PHASIX mesh. And they report a lesser rate of complication using the PHASIX mesh, and it was published this month. And then, before conclusion, we have to say that all our PHASIX cases are included in a prospective register, and Jan Müller from Strasbourg will publish our results, including grade 3 and grade 4, with very good results, as you can see, and we hope that this publication will be soon accepted. As a conclusion, before a good mesh, please perform a good technique with good preparation. Actually, in Reims, we use PHASIX for complex cases and for loss of domain, because these meshes are effective in case of infectious complication. All our PHASIX cases are included in the prospective study and are published by Strasbourg. And these good results should be confirmed in a long-term analysis. Thank you so much for your attention.
Thank you very much, Johan. It remains in this discussion about biosynthetics and slowly resorbable meshes. It remains always to be seen of all those patients who had no recurrences. Is it the influence, still the influence of the mesh, or is it a good technique, a good correction without a mesh? We give sometimes a good result. We don't know yet. We need histology after long follow-up, long-term follow-up, and to answer this kind of questions. I will proceed with the next speaker and give the word to one of our moderating team to introduce him. Who is the moderator introducing Ian Daniels? Nobody? So I will.
It will be Neil Smart instead of Jan Daniels. Neil Smart.
Okay. Well, Neil Smart, everybody knows him, of course, since decades already one of the authorities in complex abdominal wall surgery. Okay, Neil. Guillaume va introduire. Okay. Who will introduce Neil Smart? Okay, well, I said already 2 sentences about him. He's very well known in the field of complex abdominal wall surgery, of course, always very innovative, and we are curious what he will speak about today.
Thank you for the invitation to talk about Gore BioA tissue reinforcement. What does the data tell us in abdominal wall reconstruction? When we have clean wounds, the debate about what mesh to use is really very settled. The data for synthetic mesh is excellent. It performs really well and has a long history with excellent data to support its use. And when we're thinking about clean wounds, we're thinking about the CDC class 1 or ventral hernia working group class 1. No one is here to try and tell you that anything is different from this. However, the debate is in the situation where we have more complexity, whether that be the CDC wound classification of 2, clean contaminated, or class 3 contaminated, or the ventral hernia working group classifications for grade 2 and grade 3. What do we do in these situations? What's the best mesh to use? That remains open for debate. And we've all seen photos, and we've probably all got situations in our own experience where meshes have been used, particularly synthetic meshes, and there's been disasters with chronic wound infections, enterocutaneous fistulas, and erosion into bowel. The disasters that happen that necessitate further surgery and which we all wanted to avoid. What does the data tell us about using synthetic mesh in these situations? Well, we've seen data from an SQIP published before. This is over 8 years old now, published in Annals of Surgery. And you can see what happens when you use synthetic mesh in clean contaminated and contaminated situations. And you can see quite clearly what the data tells us about all of those undesirable outcomes. I'm not certain that any of us are really comfortable with having rates of sepsis and septic shock very much higher than the background. And so that's led to a real desire to have better meshes rather than what we've already got. Delayed absorbable synthetic meshes go by a number of names, whether they are biosynthetic, bioresorbable, whatever. But what they essentially are polymers which have resorption characteristics that mimic the biologic meshes that are out there and allow for tissue ingrowth and collagen deposition. They're cheaper than standard biologic meshes, and most of them undergo resorption with known characteristics because of hydrolysis rather than because of enzymatic degradation. And there are a number of meshes that are available on the market. Vicryl is probably the one that's been around for the longest. It isn't really delayed absorbable as such. It tends to be quite rapidly resolved. But other ones out there include Phasix, Tiger, and BioA. BioA is a copolymer. It's got polyglycolic acid and TMC. It's got a 3D structure, which is 1.7 millimeters thick. And as it undergoes resorption, you get one-to-one replacement with type 1 collagen. So you get a thick band of collagen left behind. There's no residual material left in the patient at all when it is fully resorbed. The resorption characteristics of the different delayed absorbable synthetic meshes have been characterized in this excellent review by Clayton Petro and Mike Rosen from the Cleveland Clinic, looking at the different times over which the different matrices are resorbed. All of them tend to have a course much longer than Vicryl and tend to have type 1 collagen left behind. However, when it comes to assessing the literature that's available, how do we go about assessing the quality of what is there? Well, when we have surgical innovation, the framework for setting out how to assess innovation was laid out in a triptych of papers in the Lancet in 2009 called the Ideal Framework. And this has now been standardized across many surgical journals, including the Lancet and many others. The idea was that you could highlight where a technology was in its implementation according to these 5 stages: the idea, development, exploration, assessment, and long-term studies that are broadly related to the types of study that were performed to assess their effectiveness. So where are we at with delayed absorbable meshes, in particular with Gore BioA? Well, most of the data that's out there is from Ideal Stage 2A studies. These are largely single institution case series, prospectively or retrospectively collected and published. The first out there was from William Cobb and Alfie Carbonell's group in the USA, looking at what happened when you had fascial closure in the overwhelming majority of cases and follow up just shy of 18 months. And what they demonstrated was that recurrence rates with BioA were no different compared to those with low-weight polypropylene or biologic meshes. The mesh type did not seem to be associated with surgical site infection or surgical site occurrence. Subsequent studies came out again from Mark Goldblatt's group, who looked again at patients often with ventral hernia working group grade 2 and grade 3 hernias in both the intraperitoneal and retrorectus position. And what we can see is that the recurrence rates when placed in the retrorectus plane are very acceptable. But what's noticeable, though, is that when used intraperitoneally, the rates were very much higher, suggesting that, like we tend to recommend generally, mesh should be placed within the retrorectus plane to give you the optimal outcome. One stage 2B study has been performed, and that was the big prospective multi-center observational study. That was the COBRA study that was led by Mike Rosen. Clean contaminated and contaminated wounds, CDC class 2 and class 3, with 104 patients enrolled on intention to treat, with 87 patients available for evaluation at 24 months. And we can see with the Kaplan-Meier curve of recurrence, by the time we reached 84 months, only 17% had recurrence rate. And the SSI and SSO events were clearly documented, and you can see that the wound events is as you would expect for this cohort of patients. So how can we summarize what data is out there? Well, we published earlier this year a systematic review looking at the ideal stage of innovation for all the bioabsorbable meshes that are on the market. And you can see that of all those that are out there, Gore BioA has got the majority of studies that is available out there at the moment, and certainly with the largest number of patients available. There were 8 ideal phase 2A and 1 ideal phase 2B study. And when we looked at risk of bias, the risk of bias tended to be lowest for the studies on Gore BioA 2. So what can we deduce when we look at the summary of the different studies that are out there? And this table from Clayton Peter and Mike Rosen again probably highlights the best situation that we have. Looking at Alfie Carbonell's study, which looked at synthetic meshes in CDC 2 and 3, Cobra study on BioWay, the Rich study on biologic mesh, and Scott Roth's paper looking at phasings. And you can see that there are a number of differences between all the studies in terms of where the meshes have actually been placed, with quite marked variation between on-lay retrorectus and even intraperitoneal. Quite marked differences between the CDC classifications, where the different mesh types have been used in terms of grade 2 or grade 3, noting that the phasix was only placed in CDC 1. There's differences in the size of hernias that have been investigated in terms of their width and actual size, and differences in terms of follow-up, in terms of how long the median follow-up was and the percentage completion. So how one draws comparisons in terms of recurrence rate is difficult to really bring together. But I suppose what we can say is that when you look at the things that we wish to avoid most of all in terms of reoperation, removal of meshes or intracutaneous fistula, it's exceptionally low for the Gore BioWay. There's one ideal stage 3 study, which is a randomized controlled trial, which is currently in progress, comparing biologic to BioWay, performed at the Carolinas Medical Center, led by Todd Henneford. It has yet to report. So where are we at? Well, we have 10 years now of clinical use of Gore BioWay and other bioabsorbables, and the data on their safety and effectiveness is accruing. They're clearly a useful adjunct in the surgical armamentarium. Our ideal stage of innovation data is progressing, but we've only got one stage 2B study with 2-year follow-up at the moment. The limitations of the study designs that we've got and the reporting challenges that come with them mean that comparison between meshes at the moment remains somewhat challenging. Thank you for your attention.
Well, thank you very much, Neil. Very interesting. And of course, the question is it the position, the retrorectus position, which makes the incidence of recurrences less, or is it that when you treat a hernia by a retrorectus mesh, maybe there's less bridging? And when all those patients with intraperitoneal meshes, maybe there were more cases of bridging. So it might be that it's not specifically the retrorectus position, but it's a better technique as a whole. We cannot exclude this, I think, but that's for later discussion. I cannot introduce a member of my own team, so I ask one of my colleague moderators to introduce Gijs de Smet, please.
Thank you, Johan. It's my pleasure to introduce Rich. I hope it is like this, Rich de Smet, for functional outcomes in symptomatic versus asymptomatic hernia patients undergoing incisional hernia repair. Do we replace one problem with the other? So it's for you.
Cher comité, merci beaucoup pour l'opportunité de présenter notre étude au sujet de la douleur post-opératoire chez les patients subissant une réparation d'une hernie incisionale. Je ne parle pas très bien français, donc je vais continuer la présentation en anglais. I have nothing to disclose. Incisional hernia remains one of the most frequent complications after abdominal surgery. The incidence is between 5 to 30%, and incisional hernia is associated with high healthcare costs, discomfort, pain, and an impaired quality of life. To prevent and treat incisional hernias, the abdominal wall can be reinforced using a mesh. However, mesh reinforcement is also associated with chronic pain. Nowadays, also due to the influence of the media, there is an increased resistance for meshes among hernia patients. We wonder if this commotion is justified, or do we actually replace one problem with another? So our primary aim was to investigate the pain reduction in preoperative symptomatic patients and the pain induction in preoperative asymptomatic patients undergoing incisional hernia repair. The secondary objective was to determine the preferred mesh type, the preferred mesh location, and the surgical technique in minimizing postoperative pain and discomfort. To answer these questions, we used the Hernia Club Registry database. All adult patients undergoing incisional hernia repair between September 2011 and May 2019 with a follow-up of 3 to 12 months, which had data on postoperative pain and or discomfort were included. Hernia patients were defined as symptomatic when they had a hernia that causes either pain, sensory complaints, or causes other discomfort problems. First, we split the data set into two groups, the preoperative asymptomatic patients and the preoperative symptomatic patients. And after surgery, we assessed the complaints from patients' surgical site. After this, a univariate and multivariate regression model was used to identify factors which are associated with postoperative chronic pain. In this logistic regression model, multiple imputations were performed to ensure maximized use of the available data, and variables potentially related after univariate analysis and factors of clinical interest were considered for a multivariate analysis. A total of 1,312 patients underwent incisional hernia repair and were included, and of these patients, 83% were symptomatic before surgery. Here we see the table with the preoperative hernia characteristics in both groups. Around 25% of patients had a recurrent hernia, and notable is the differences in patients that had previous surgery with mesh. Patients with an intraperitoneal onlay placed mesh had significant more complaints compared to the other mesh locations. Also, patients with a large hernia have significantly more complaints compared to the smaller hernias. In this flow diagram, it shows the pre- and postoperative pain and discomfort. Notable is that 20% of all preoperative asymptomatic patients reported pain or discomfort postoperatively after a median follow-up of 11 months, and around 70% of all preoperative symptomatic patients had no postoperative complaints, so nearly 30% remained symptomatic. This table shows once again the postoperative discomfort after median follow-up of 11 months, but now with the discomfort specified with VAS or an NRS score. Multivariate analysis showed that any preoperative discomfort is associated with postoperative discomfort. Also, mesh fixation with the use of tackers or using a self-adhesive mesh is associated with postoperative pain or discomfort. So in conclusion, in symptomatic incisional hernia patients, hernia-related complaints may be resolved in the majority of cases undergoing surgical repair. However, in asymptomatic incisional hernia patients, pain or discomfort may be induced in a considerable number of patients after surgical repair. Preoperative discomfort is a risk factor for remaining or inducing pain and discomfort, and additionally, mesh fixation using tackers and self-adhesive meshes is associated with chronic postoperative pain. In this cohort, a considerable number of preoperative asymptomatic patients underwent surgical repair. For some patients, the shame of the cosmetic appearance of the ventral hernia is a more prominent reason to undergo hernia repair rather than pain or discomfort complaints. Another reason to repair a ventral hernia is the risk of incarceration. Some studies showed that watchful waiting for incisional hernia is safe. However, one study showed that watchful waiting leads to high crossover rates, with significantly more incidence of intraoperative perforation, fistulas, and mortality for emergency surgery. Then, can we explain the outcomes of this study? the peritoneum is known to be intensively sensitive to pain. This could be the reason why we observed that preoperative patients with already an intraperitoneal onlay mesh had more complaints compared to the other mesh locations. However, this was not seen after multivariate analysis. Also, we found that patients with a large hernia have significant more complaints compared to the smaller hernias, which seems to be very logical. However, the small hernias of 3 to 4 centimeters of size are more at risk for incarceration. Additionally, the traumatic mechanism of Tacker's and self-adhesive meshes can be a good explanation why these fixation tools are associated with postoperative chronic pain. This cohort study has, however, some limitation. First of all, pain is a relatively subjective measurement. However, to minimize this effect, we assessed multiple aspects of pain and discomfort in this cohort. Although all data was collected prospectively, the results may be influenced by selection bias due to the observational study design. Furthermore, only surgeons specialized in abdominal wall surgery performed the hernia repair. With this in mind, we can assume that this study represents a relatively low rate of complication, and that chronic postoperative pain might be underestimated in this cohort. With this study, we recommend to inform your incisional hernia patient about the risk of postoperative pain, especially when it concerns an asymptomatic patient. Furthermore, we recommend using sutures instead of tackers or self-adhesive meshes to prevent postoperative discomfort. We would like to thank all surgeons and research associates of the Hernia Club, and especially Dr. Guillon, for collecting all the data. Thank you very much.
Thank you, Gijs. As we have to say it, I saw that Dr. Guillon was very pleased when you started in French, and I told him we worked together on this for a month, and the result was very good. Thank you very much for that. Of course, your presentation underlines the traditional, the old topic of the asymptomatic hernia, what to do with it. Everybody nowadays will be reluctant to operate, and your results seem to support that. But otherwise, some of these asymptomatic hernias will grow, and then of course the incidence of recurrences and complication will be higher if you operate after some years. That's a very interesting point of discussion. The last speaker of this session, Michel Prudhomme, will be introduced by one of our mediators. Please.
So I have the privilege to introduce the last speaker of the session. We are perfectly in time, thanks to the organization. It's Professor Prudhomme. He's head of the digestive and cancer surgery in University Hospital of Nîmes, France. And Dr. Prudhomme is going to talk about parastomial hernia. And he's the co-author of the European Hernia Society guidelines for prevention and treatment of parastomial hernia. And I think that his communication is a perfect symbol of the improvement in management of wall issues by an international cooperation that is really, for me, rewarding, inspiring. And I like to thank again Jean-François Gillon to be the conductor of our orchestra of working on the abdominal wall, because this is really, each year it's nice, it's better, and it's really pity not to be all together, but physically, I say, this year, but I'm sure next year it will be a very, very nice and enthusiastic session. So, Mr. Prudhomme, many thanks to present your communication.
Cher Jean-François, merci pour cette invitation, somme toute un peu particulière, mais j'ai toujours plaisir à venir présenter au congrès MESH que tu animes depuis plusieurs années. Voilà, je vais vous présenter un sujet qui est toujours d'actualité et qui est pour l'instant sans fin et sans point final, qui est la prévention des éventrations péristomiales. Que faut-il faire? Comme vous le savez, les éventrations péristomiales ont une incidence de près de 50%, tout en fonction du suivi que nous organisons. Plus ce suivi est long, plus cette incidence est élevée. Elle va entraîner des difficultés d'appareillage pour les patients, elle va compromettre l'irrigation colique, ça altère grandement leur qualité de vie, c'est du reste leur principale plainte, cette éventration péristomiale, et parfois ça entraîne, comme sur cette vue de scanner, des complications majeures type occlusion ou strangulation. D'où l'intérêt d'une prévention, d'autant plus que le traitement de ces éventrations péristomiales est souvent difficile et souvent morbide. Alors, on a écrit des recommandations en juin 2016, j'ai eu la chance de pouvoir y participer, concernant la prévention de ces éventrations. Et est-ce qu'il existe une technique autre que la mise en place d'une prothèse pour éviter ou limiter l'apparition de ces éventrations péristomiales? Eh bien, nous n'avons pas retrouvé ou retenu d'autres techniques que la mise en place d'une prothèse. Aussi, nous avons recommandé à cette époque l'utilisation de prothèses synthétiques prophylactiques lors de la création d'une colostomie. Alors, cependant, on peut se poser la question de est-ce qu'en pratique, depuis 2016, nous mettons systématiquement des prothèses lorsque nous construisons une colostomie? Eh bien, voici une étude qui a porté sur des questionnaires qui ont été adressés aux chirurgiens colorectaux européens. Et ce questionnaire était justement de savoir s'ils ils mettaient en place systématiquement des prothèses lorsqu'ils faisaient des colostomies. Bien, vous voyez que moins de 10% de ces membres faisaient de façon systématique la prévention de ces éventrations par prothèse. Donc, ce n'était pas rentré clairement dans les mœurs. Et pourtant, il y a eu de multiples études randomisées, de multiples méta-analyses. Je vous rapporte ici la plus récente, celle de Jones de 2018, où vous voyez les études randomisées, plus de 10 études randomisées avec des faibles effectifs malgré tout, 771 patients. L'évaluation était clinique et ou radiologique. Et ici, seulement à 1 an, car il y a peu d'études avec un suivi à plus de 2 ans. Et vous voyez que la mise en place d'une prothèse diminuait par 2 le taux d'éventration péristomiale. Les auteurs rapportaient une hétérogénéité importante de ces études et un niveau de qualité faible. Ces auteurs insistaient sur la nécessité, malgré tout, d'une étude randomisée supplémentaire avec une plus grande population et un plus long follow-up pour avoir plus d'informations concernant cette prothèse, la localisation de cette prothèse, la qualité de vie des patients et bien sûr s'il y avait des effets secondaires à long terme. Alors cette conclusion venait parfaitement au moment où nous avons publié, où nous avons eu les résultats de l'étude GRECAR7, qui est une étude que j'ai pu mener de façon multicentrique avec le groupe GRECAR, qui est un groupe de recherche sur les cancers du rectum. Nous avons inclus plus de 200 patients randomisés en 2 groupes, un groupe avec prothèse positionnée en position rétromusculaire, c'était des prothèses de faible grammage, monofilament, et un contrôle groupe qui était un groupe classique de création de colostomie. Cette prothèse était positionnée par voie rétromusculaire avec une voie d'abord par voie stomiale. La prothèse était insérée donc en rétromusculaire, le côlon passait à travers la paroi, à travers la prothèse. La prothèse avait une incision en son centre qui était cruciforme, permettant donc le passage du côlon. Quel était le taux d'éventration péristomiale entre ces 2 groupes dans cette étude? Eh bien voilà des résultats décevants avec des courbes parfaitement similaires, aucune différence statistique, que l'on mette une prothèse ou pas de prothèse dans le taux d'éventration, pas de différence dans le délai d'apparition de ces éventrations péristomiales. Quand on regarde en sous-groupe, il y avait peu d'éventrations symptomatiques, mais avec un taux équivalent dans les 2 groupes. Pas de différence en termes d'éventration dépistée par la radiologie, 34 dans le groupe sans prothèse versus 22% dans le groupe avec prothèse. peut-être un peu moins de réintervention dans les patients qui ont eu une prothèse rétromusculaire pour la prévention de leur éventration, mais ce n'était pas statistiquement significatif. Alors, est-ce que c'est la seule étude randomisée que nous avons à notre disposition? Mais il y a une autre étude randomisée qui est l'étude StomaMesh. Cette étude StomaMesh qui portait sur 6 centres en Suède et où l'on voit clairement que ces taux sont rigoureusement identiques, ce qui est même surprenant. Avec par contre un follow-up à 1 an, 201 patients, vous voyez que là aussi, pas de différence significative en termes d'éventration péristomiale à 1 an. Autre étude qui vient de paraître dans Disease Colon Rectum cette année, c'est l'étude à long terme de l'étude de Very et Emma, qui a proposé donc la position de ces prothèses. Et ici, avec un follow-up de plus de 5 ans, on voit qu'il n'y avait pas de différence significative dans les éventrations, qu'elles soient diagnostiquées cliniquement ou radiologiquement, avec là aussi moins de réintervention de façon ici significative dans le groupe qui a eu une prothèse versus le groupe qui n'a pas eu de prothèse. Encore une fois, un long follow-up et par contre, plus de 50% de perdu de vue. Ici, une voie d'abord laparoscopique et une voie d'abord intrapéritonéale avec une kéole mesh, alors que stomamesh et Grécar sont des voies rétromusculaires. Alors, discussion assez embarrassante quant à l'intérêt d'une prothèse pour prévenir du risque d'éventration péristomiale. Est-ce que c'est efficace? Ben, apparemment non. Est-ce que ça a une faible morbidité? Eh bien, très certainement, oui, faible morbidité. D'où la nécessité de revisiter les recommandations européennes pour rediscuter de la place de ces prothèses et certainement la place d'une nouvelle méta-analyse en fonction des résultats de Grécar 7 et des résultats à long terme des études intrapéritonéales. Alors, est-ce que ces résultats décevants sont dus aux chirurgiens? Dans le groupe Grécar, ce sont des chirurgiens colorectaux et pas des chirurgiens de la paroi, pas habitués à ce type de chirurgie. Est-ce que c'est dû au design de la mèche, qui est plutôt adapté à une chirurgie pariétale et pas tellement à une stomie? Est-ce que c'est l'incision cruciforme au sein de cette prothèse, donc l'équivalent d'une kéole technique qui favorise le shrinkage et donc l'élargissement de l'orifice de la stomie et donc qui favorise l'éventration péristomiale? Est-ce que c'est dû à un défaut de fixation? Il y a des fixations différentes dans les différentes études. Est-ce que c'est la localisation de la prothèse? Et là, il y a un vrai débat à avoir sur est-ce qu'il faut positionner mieux ces prothèses en position rétromusculaire? On a vu que les études avec des positions rétromusculaires sont négatives. Ou est-ce qu'il vaut mieux positionner ces prothèses en intrapéritonéale? Intrapéritonéale, eh bien, voilà une des études randomisées de la voie intrapéritonéale où la prothèse est utilisée selon la technique de Sugar-Baker, où il n'y a pas d'orifice créé dans la prothèse. C'est la technique classique recommandée pour la chirurgie de réparation de l'éventration péristomiale. Ça peut se faire par laparotomie, par laparoscopie. D'après cette étude, il y a une durée opératoire limitée, mais ce n'est pas toujours aussi simple à positionner, ce n'est pas aussi court en termes d'intervention, c'est surtout responsable d'adhérence viscérale, parfois d'occlusion, parfois de migration de ces prothèses, et mettre en place de façon préventive une prothèse en position intrapéritonéale est quand même délicat à proposer à un patient. Ici, l'exemple, ça, ce sont des photos personnelles d'une mise en place de ces prothèses. Nous n'avons plus de prothèse type pour la prothèse intrapéritonéale. Nous devons donc pour l'instant nous débrouiller. C'est un appel ici aux industriels pour développer ce type de prothèse. Et vous voyez que cet ancien modèle, avec le déchirement de la prothèse, mais aussi de nombreuses adhérences au contact de la prothèse, qui fait que, encore une fois, ce type de prothèse en intrapéritonéale pour une prévention est quand même délicat à proposer. Qu'est-ce que nous avons dans la littérature pour étayer le choix entre une voie intrapéritonéale ou rétromusculaire? Et vous voyez que pour la position intrapéritonéale, encore les résultats de cette méta-analyse, pas d'évidence nette à mettre une prothèse en intrapéritonéal de son efficacité quant à la prévention des éventrations péristomiales. Donc effectivement, c'est un peu un sujet d'actualité et le débat n'est toujours pas clos. Est-ce qu'il faut complètement abandonner la mise en place de ces prothèses pour prévenir des éventrations péristomiales et se résigner à avoir plus de 50% d'éventrations péristomiales quand on fait une colostomie? Eh bien, je ne pense pas que ça soit la bonne idée et je ne pense pas que nos patients soient d'accord avec cette attitude défaitiste. Est-ce que nous devons mener de nouvelles études randomisées avec une prothèse intrapéritonéale et la technique de Sugar-Baker? Nous pouvons en discuter. Il n'y a pas beaucoup d'études sur la voie intrapéritonéale et la technique de Sugar-Baker. Est-ce qu'il y a par contre une étude en cours qui utilise une voie intrapéritonéale? Ici, j'ai représenté une photo de cette étude avec une prothèse qui est une prothèse Dynamèche positionnée en intrapéritonéal, mais avec une technique de Kehl technique. Je ne suis pas sûr que les résultats soient aussi bien meilleurs qu'une voie rétromusculaire. Évidemment, nous devons développer d'autres formes de prothèses, des prothèses 3D. J'ai certainement des idées par rapport à ça pour avoir une meilleure couverture pariétale et surtout limiter les frais de shrinkage qui favoriseraient les éventrations péristomiales. Vous voyez donc que nous avons encore plein de discussions et certainement de présentations à vous montrer sur la prévention des éventrations péristomiales. Je vous remercie de votre attention.
Thank you, Dr. Prudhomme, for addressing still an enormous problem in abdominal surgery. And of course, we have to look for the best method of putting our meshes for prevention. But at the same time, we have to wonder if our transrectal technique to construct our stomas will be the best. And there are varieties, for example, pararectal techniques which seem to give better results. We have to consider all that. I think also a nice topic for discussion, which will be led now by Pablo, and I'll give him the word.
Yes, we have some questions from the public, from the attendees. So with Jean-Pierre Cosa, we are gathering questions for each presentation. So regarding the two first presentations, we have two questions. As Dr. Bueno Yedo is not here with us to answer, I'm sure that Miguel Ángel García Ogueña will be able to answer to both questions. The one for your technique, Miguel Ángel, is a question regarding the duration of the operation. So how long is the operating time? It's a question from Pierre Blanc for Miguel Ángel García Ogueña.
Okay, of course, the posterior component separation is more tricky than the anterior component separation. Takes longer time. There's no doubt about that. But probably the time of the procedure depends on the time of adhesiolysis. No, the time depends on the previous procedure, the condition of the patient. But probably a posterior component separation, it's itself. Maybe it's a 2 hours procedure to make all the dissection, but also it's not only this dissection, it's only to release all the all the adhesions to the parietal abdominal wall.
Of course, it's all the previous work.
Yeah.
And there is a second question that it was addressing the first presentation, but I know you know the answer, Miguel Ángel. It's about, do you consider that a previous star is a contraindication to a Ramirez? So can you perform simultaneously an anterior and a posterior component separation technique? And I know you have published recently a very nice article on that topic.
Okay, my advice is not to perform a combination of this procedure, almost in exceptional situations. But if you have a previous anterior component separation or previous posterior component separation technique performed, you can try to solve the problem with the other technique. No, but first, don't recommend to have it as a tool, only as an exceptional resource of technique. making it in combination. In previous attempt of anterior, of course, it was published by the group of Nowicki and Rosen, the use of posterior component separation after the recurrence of an anterior. I think it's quite a good technique. If I have a posterior component separation, I have a recurrence. In fact, we have 4 recurrence in the midline. We have made again our way in the retromuscular in 3 cases. And in another one, we had an anterior component separation technique.
And Miguel Angel, does it happen to you to perform only an unilateral component separation technique, or it must always be a bilateral procedure?
For midline, I almost systematically do bilateral if it is indicated, no, because it's a large defect. But in lateral, in iliac, subcostal, or lumbar, maybe I only add an unilateral posterior component separation technique.
Okay, so we have other questions about communication of Johan Renard. Johan, first of all, an anonymous comment about the risk of vascular injuries when you create pneumoperitoneum. Did you experiment vascular injuries due to adhesions?
During the performing the pneumoperitoneum, no, we have not so much complication performing the pneumoperitoneum. Sometimes it is when we introduce the air into the subcutaneous compartment, but we didn't have very much complication. I had one very high complication, but it was only during emergency, and we insufflate into a vein, and the patient had a permeable foramen in the heart, and she developed intracerebral emphysema, but it was only during emergency. But when we perform regular pneumoperitoneum, when it is anticipated and so on, I didn't have any hematoma complication.
Okay. Jean-Luc Bouillot is asking you, where do you put the mesh phasics when you perform your repair, intraperitoneal or retromuscular?
Yes, it's a very good question, of course. As we use this strategy to perform in one-step repair, and as we know that the sublate repair, retromuscular repair is the best, I use always, whenever possible, the mesh in the retromuscular compartment, always, whenever possible.
Okay. Well, question for NailSmart. You mentioned that you observed more complaining patients when previous intraperitoneal mesh repair. You say that the reason is about tackers or self-adhesive meshes. How do you explain that self-adhesive meshes generate more pain?
So I think that was for Heiss, isn't it?
Yes, I think that question is for me. Yes, it's difficult to say because we saw it after the multivariate analysis, and we wonder ourselves what causes this this result. And yeah, we wonder maybe it's the little hooks that maybe some nerve traps into it. So that's I think one thing that could be the answer, but it's really difficult, and I think there must be further research, further evaluation in the future on the self-adhesive meshes.
I have another question for you. I have listened to your warning message regarding asymptomatic patients, but we have also recent papers showing the natural history of incisional hernia that is most of the time increasing in the time and becoming symptomatic. So at the end, in the practical day, what would you do? You would avoid surgery in asymptomatic patient, or you would recommend surgery with a preoperative information that sometimes we create a problem that the patient did not have before?
Yeah, thank you for that question. I think that is a really relevant question. First of all, I think you have to discuss this with your patient, so you make a shared decision to operate or not. And what you say, indeed, some hernias will grow over time. And I think if your asymptomatic patients first do not want to undergo surgery, you have to monitor, you have to follow up very carefully your patient. And when it will grow, I think you as a doctor have to say to this patient that you think it's better to operate. So, but that is on the decision of the doctor, of the physical, and also a little bit of the patient. Yeah.
May I comment on it? We learned from the French registry and also from our data that there's a clear correlation between the size of the defect and the outcome. So that means, as we know that an incisional hernia always grows, makes no sense to wait for a larger defect with more complications. So I would not advise, on the basis of our data we have, to postpone a incisional hernia repair. The other thing you can say, patient can decide a good time of the year when he wants to be operated, but it makes no sense to set him on a waiting list for a long time.
All right, yeah, that's,
Can I make a comment also in this interesting communication? Because do you think, Dr. Lance Bryce-Smith, that maybe also the results are part of the method of fixation of the prosthesis? Because now we are now describing more and more techniques that make any kind of fixation to the mesh. You know, we are watching Miller's technique without fixation, Reeves' technique without fixation, and can be that part of the problem that we maybe we have fixed too much the meshes in the retromuscular position. What do you think about this?
Yeah, that depends. I think also in this morning some other presentations were on the IPOM and the sublay and the onlay positions, and I think also from this study the sublay is preferred, the sublay position. In contrast to the intraperitoneal onlay mesh and the retro of and the onlay position of the mesh. But I don't know what do you think about it, the other speakers.
Okay, we have another question for Michel Prudhomme. Which mesh would you recommend for Sugar-Baker technique?
Well, we don't have a mesh now, a standardized mesh. We have to play with, I use for myself the biomesh, not the biosynthetic mesh, actually, because we have to find a mesh with two faces for the viscera, and this is the only one that I can use. Or sometimes what we can do, it's modeling one mesh currently used for an intraperitoneal way, and we make a special end surrounding the colon to have two parts of visceral part, if you understand. Yes. Not to have only a part, parietal part on the colon. So it's a problem, because I think we need a mesh, a new kind of mesh for the treatment.
Yes, can I speak? Can I say something? I totally agree with Professor Prudhomme. For myself, I perform my own mesh using a biliary mesh that I use one of both, and cutting this mesh, it's possible to perform a sugar bucker mesh.
Yes,
But
absolutely, I agree too. Johan, puisque tu prends la parole, I have a question for you from the audience.
Yes.
Were you about infection with phasic prosthesis? Were you able to manage infections without removing prosthesis?
Yes, no, of course not. I think when we use physics, when I use physics mesh on stage 4, grade 4 infection, that's to say when there is in place an infected prosthesis, the first objective is to remove the mesh. I think it is not possible to make something else. So first we remove the infected mesh, and after we use the physics to reconstruct the abdominal wall. But the first objective for this situation is to remove the mesh and all the device of fixation, for myself, in my opinion.
Okay. And concerning the risk of vascular injuries due to adhesions in pneumoperitoneum, we have a precision from the audience about the risk of it means the risk of distension of adhesions when performing pneumoperitoneum, which can lead to tearings of little vessels. Did you expect that?
Okay, I thought it was the risk using the needle on vessels. No, okay, I understand that the question is the risk of elongation of the bowels into the sac. Yes. No, I didn't see this complication in my experience. No, sometimes we can see in the preoperative CT scan that there is some elongation on the sac, but I didn't see any bleeding on the bowels during this situation. Yeah.
However, this is communicated this is reported in the literature, Johan. There are cases of intraperitoneal bleeding during the Goni-Moreno technique. That's
yes, yes, of course. Yeah, I agree with you. I saw this publication, but
we had one case in our publication of a bleeding after pneumoperitoneum. Yeah. And I ask the question about the subject of loss of domain. I like to know in the team which already use Botox, do they have experience in using both Botox and Goni-Moreno technique? And if it is the case, it may be the subject of a prospective study, I think. And I have no idea actually how many teams perform using both of the techniques, Goni and Botox.
Well, I know Frederick Berrevoet in Ghent. He had a rather extensive experience with it of about 40 patients now, and the results in short are about 25% recurrences and 40% surgical site infections.
We are also performing both techniques simultaneously, Catherine, and also other teams in France, Guillaume, and I know that David Moscovic is trying to build on a trial, a multicentric trial to compare, to assess if we can decrease the number of component separation technique when we use both techniques.
Great.
In our group, we are currently using Botox and the combination of Botox and pneumoperitoneum for complex loss of domain cases. And we are now currently introducing also, as Dr. Bueno in Valencia, in those cases less than 10 centimeter in high morbidity patients that probably, they would need a component separation technique to avoid the component separation using the Botox as an adjunct to the repair, to avoid and to make only a reverse stopper in those high morbidity patients.
So we are reaching the time. I don't know if you have any final comment before we ask Professor Koekeling to close the session. There is. Oh, Johan, excuse me, it's your session. Any comment? Any final comment?
No, I think that it was a very good session, in my opinion, and I learned something. Of course, there are still questions remaining, such as why not operate on asymptomatic small hernias if there is a real chance those hernias will grow and will become symptomatic? Why not operate these hernias in an easy way with a minor operation? That's the question which remains. And the other question, the major question of the session, I think, what will those slowly resorbable meshes generate after 10 years? Maybe we can hear the answers in Paris at that time. I'm happy to give the word to Ferdinand.
Yeah, Jean-François asked me to say some words at the end of the international session. It was a great session, so I learned a lot. Very high standards, very nice videos, excellent tips. I'm sure everyone who had participated will profit from it. It was outstanding, very, very good. So I'd like to thank Jean-François putting this session together, inviting an international panel of experts presenting their knowledge and their tips and tricks. And I think this is the way we have to go. We have to learn from each other. We can extract many important knowledge from the various registries and databases all around. We should work together, and I'm sure our patients will profit from that in the future. And I hope we will meet soon together face to face again, that we have the pleasure that this terrible corona crisis is over and we can return to normal activities. There's a lot of things to do. Let us hope all that we soon return to normality. So thank you very much to the French surgeons. It was a pleasure. We have to keep Europe together. So we must be strong that we can go on the way we have already done before the corona crisis. So thank you very much again. It was a great experience. Thank you.
Thank you very much.
Bye-bye.
Thank you very much, Ferdinand and Dirk. The session in English is finished. Now we will follow in French, so you can those who don't understand French are allowed to leave us. And Johan, tu peux rester, toi qui parles un très bon français, ça sera avec plaisir. Je reprends en français. Donc, on va avoir une pause à peu près d'1 heure, une pause déjeuner. On reprendra à 2h30 pour des communications là également de haut niveau, mais en français, et pour la conférence de clôture de Pablo. N'éteignez pas complètement vos computers pendant la pause, car nous allons avoir des informations de la part de nos partenaires industriels. Je vous rappelle que ce congrès ne pourrait pas avoir lieu sans eux. Et donc, vous pouvez manger votre sandwich devant l'écran. On se redonne rendez-vous à 14h30 et encore, je vais le dire en français puisque Ferdinand l'a dit en anglais, vraiment cette session du matin était excellent avec des topos excellents et je pense que ça va être aussi bien l'après-midi. À tout à l'heure à 14h30.